All right. Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Breast Cancer Health and Awareness. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and education programs like this workshop. Education programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Without further ado, I introduce our workshop speaker. Dr. Priya Mitra started her career in internal medicine and then transitioned to radiation oncology in 2007. She currently works at UCI Medical Center and treats all cancers with a specialized focus in women's cancers. Thank you so much for being here with us today.
Okay, thank you all so much. I really appreciate you being here. Let me start to share my screen. Okay, hopefully you guys can all see my screen. So
Yes.
great. So welcome. My name is Priya Mitra and I work at UCI, as Rebecca mentioned. The topic today is breast health and cancer awareness, as October represents Breast Cancer Awareness Month. So we thought this might be an opportunity in which we could discuss relevant topics. So just a little bit of background and introduction about myself. So medical training wise, I actually did 3 years of internal medicine at Boston University Medical Center after graduating medical school. After that, I decided to subspecialize in radiation oncology. I did my training in Richmond, Virginia at VCU. And now I currently work at UCI. My specialty is breast and gynecologic cancers. I was previously at USC, but now based at UCI, both great institutions. So grateful to be here. And that's our phone number in case I can ever be of service. Feel free to reach out to me or our team, and we'd be happy to help. So today, the topics that I picked out, there's 6 of them. Most of them, interestingly, started with an S, so I highlighted that. So what I'll do is I'll pause after each section just to make sure and see if there's any questions that arise. I love questions. The more you ask, the better. I think a lot of times when you have a question, other people have a question, the same question, it's very common. So the more you ask, I think it's just educational for everybody. And I'll do my best to answer all your questions. So the topics for today, we'll talk a little bit about statistics and risk factors. Then we'll talk about what the recommendations are for screening. And then we'll go through and talk about the different scans. How do we detect breast cancer? Then we'll talk about signs and symptoms, things that you can watch out for and look for, tell your family members and friends about too. And then we'll talk a little bit on treatment and then talk about some special circumstances. So part 1, statistics and risk factors. So this is a slide, and I try to incorporate as many pictures as possible because I find that helpful rather than just lots of words. So the top half of this slide is estimated new cases diagnosed in the United States. And on the bottom is the number of deaths from that cancer. So as you can see is highlighted, like on the right is women. Breast cancer is diagnosed in new diagnosis of almost 300,000 cases. So about 30% of all cancers diagnosed in women in the United States is represented by breast cancer. The number 2 cause of death related to cancer in women is breast cancer, about 15% of all deaths. Lung cancer is highest, and that's the case for men and women. But definitely the highest incidence of cancers in women is breast cancer. So some statistics, about 30%, as I mentioned, of all newly diagnosed cancers in women are breast cancer in the United States. Another way to think about it is 1 in 8 women will develop breast cancer. The good news is that 2/3, about 66% of breast cancers are all early stage. What that means is it's caught early and we can cure it vast majority of the time. One other thing we'll talk about a little bit later is that less than 1% of breast cancers actually occur in men. A lot of people don't know that men can get breast cancer as well. So I've definitely seen it. I've definitely treated them. Many of them have a genetic predisposition to it, and we'll touch on genetics a little bit later as well, but you can have it just like women can have it also. So risk factors, the two most common risk factors are one, being a woman, and number two, increasing age. So both of those are things that are out of our control. But there are some things that are in our control that can impact our risk for breast cancer. So lifestyle factors, if you have an increased BMI, I'm not sure if everybody's familiar with what BMI stands for, but it stands for body mass index. It's basically there's a calculator. If you Google BMI calculator, you can put in your height, you can put in your weight, and it calculates your BMI. If your BMI is 30 or greater than 30, essentially, that classifies as obese. Normal range is roughly 18 to 22. And so that's something that, is in our power that we can help control sometimes when with diet and exercise. Alcohol use can be a factor if somebody's drinking a lot of alcohol, and we'll touch on this a little bit later as well. Prior use of hormones. So these are things that I ask patients when I meet them when they're referred to me with a new diagnosis of breast cancer. Did you take birth control pills? Did you take hormone replacement therapy for menopause? Because sometimes they can be associated with an increased risk of breast cancer. The reproductive history. So a lot of this basically ties into estrogen exposure. So if somebody is very young at the age of when they first start their period or menarche, I have a friend whose daughter just got her period at the age of 9. That's going to typically correlate with a longer lifetime exposure of estrogen or to estrogen. Late menopause, same thing. The average age is in the early 50s, but we've had some women who come in and they're hitting menopause mid 50s. If you've never been pregnant, that can also be a risk factor for breast cancer. Clearly, that's not a reason to go get pregnant, but just something to be aware of. Also, if you are at an older age, typically greater than 35, when your first child is born, that can also be associated with a risk factor for breast cancer. Prior radiation therapy to the chest. This is something that's really important to us in the world of radiation oncology. Historically, for patients who would get lymphoma meaning a cancer of the lymph nodes, the classic location or very common location is the chest. So if we were giving radiation to the chest, a portion of the breast were getting exposed. And they were often, a lot of times it's children who get diagnosed with lymphoma. So when they get radiation at a younger age, they're higher at risk for developing breast cancer. So they actually need to start screening for breast cancer earlier. The last thing on here is family history, and only roughly 5 to 10% of cases of breast cancer are related to family history. That's probably one of the most common questions I ask or that I get asked when patients come in. They'll say, well, I don't understand why I got breast cancer. Nobody in my family has breast cancer. But as I mentioned, only 5 to 10% of cases are hereditary. Really, just as we increase our age and being female, those two factors in and of themselves are the biggest risk factors. So what about protective factors? So menopause before the age of 45, so early menopause can actually be helpful. Again, not that we have control over that. Exercise, which correlates with BMI, a lot of times. Breastfeeding can also be a helpful protective factor. If you look online, there's lots of risk calculators in terms of what is my risk, what is your risk of developing breast cancer, which factors in your age, abnormal mammograms, prior biopsies, family history. So those are things that you could look up if you're curious, or you could ask your doctor about. So what are some healthy lifestyle habits to reduce the risk of breast cancer? So alcohol, it basically disrupts or negatively affects the estrogen metabolism. So the recommendation is to limit alcohol to a maximum, if you can, of 1 drink per day and no more than 3 drinks per week. Now, I know a lot of women will drink a glass of wine a day, or a lot of, or have a little, 1 drink a day. And, it's not that if you have 4 drinks a week, or if you have 1.5 drinks a day, that's an automatic guarantee that you're going to develop breast cancer, but it does slowly increase the risk. Exercise. The recommendation is to exercise approximately 2.5 to 5 hours of moderate intensity every week. Now that sounds like a lot, but 2.5 hours is basically 30 minutes, 5 days a week. So the goal is to try and be active in some way, shape, or form on a daily basis, whether that's, parking far from the grocery store or from the mall and walking a little bit, taking the stairs sometimes instead of the elevator. These little things really do make a big difference. And then back to weight, keeping your BMI less than 25. So I'll pause there before we move on to screening. Any questions so far about what we've discussed?
If there are any questions, feel free to put them into the chat as you think of them, or you can unmute yourself and then indicate to me that you have a question to ask.
Yeah, and you're welcome to submit questions as I'm speaking too, and then we can address them when we take pauses.
Okay, I think we're good on questions so far. Thank you.
Yep, yeah, this is pretty basic stuff. Okay, so part two is screening. So this is really just the only main slide that I have on breast cancer screening. So there's different organizations. There's the American Cancer Society, the ACOG, or American College of Obstetrics and Gynecology, and the USPSTF, which is the US Preventative Services Task Force. So the different organizations have different recommendations for breast self-exam, clinical breast exam, and MRI. But what I wanted to highlight, what the main thing to focus on is mammograms. So the American Cancer Society recommends annual screening starting at the age of 45. So once a year, getting a mammogram. The ACOG recommends getting annual screening starting at the age of 40, and the USPSTF recommends 50. So we've got 40, 45, and 50. I recognize that I'm very biased, but I've definitely seen a lot of young women diagnosed with breast cancer. I mean, I saw a patient last week who was 26 years old, which is obviously atypical. And she's getting genetics testing to figure out if that may be a contributing factor to her, just because that's so abnormal. But I think the take home is somewhere between 40 and 50, one should start getting screened with mammograms. Now, in women who are high risk, if they do have a strong family history and they've got mutations such as a BRCA mutation, which we'll talk about later, and sometimes in those women, MRI screening can be incorporated into it. Ultrasounds can be incorporated into screening as well as clinical breast exam and self-breast exam. Any questions about screening? Okay, I'll keep moving. So I want to spend a little bit of time about scans. I don't know how many of you have had imaging studies done for breast cancer screening, but there's really three main things to be aware of. One is mammogram and tomosynthesis. I feel like mammogram is a very popular word that people are very familiar with. Tomosynthesis, not so much, and I'll talk about that a little bit. Ultrasound and MRI. So let's start with a mammogram. So this is a pretty routine appearance of a mammogram. So there's a plate, this black plate. I don't know if you can see my ruler or my arrow moving, but there's a black plate here onto which the technician will assist the patient putting the breast there. And then this white plate on top comes down and gets compressed. So it kind of basically squeezes the breast and makes it somewhat flattened. So this view is from top to bottom. And then they also do a oblique view or side to side at a bit of an angle, which is the picture on the right. Both of those are pretty standard views. So this is called craniocaudal and this is called MLO or medial lateral oblique. And we do that on both sides, right breast and left breast. Here are some sample images of what it looks like. So on the top left, there's a picture of a mammogram. So the two top pictures are the craniocaudal, where it's compressing the breast from top to bottom. And then that angled view is the bottom two pictures. So abnormal mammograms, I've got the next three pictures. So on the bottom left, you can see these whitish, almost looks like pepper or salt. And those are calcifications that are abnormal. Sometimes they can be benign, sometimes they can be abnormal, but something like this would probably, there would be a recommendation to get a biopsy or at least additional imaging to find out. So in the middle picture, you can see the arrow pointing at there's a lesion there. So everything else here within the breast is pretty normal, but that's an example of a small abnormality that again would typically be followed up with additional imaging. And then here on the top right, you can see hopefully this is a pretty big, large density within the breast that looks abnormal. So the pictures on the mammogram that we take, the craniocaudal and the MLO views, the purpose of those is screening. If there's any of these findings that are found on the screening mammogram, what happens next is that they typically will call a patient back to do what's called a diagnostic mammogram. A diagnostic mammogram is basically where they just focus on the spot where the abnormality was seen. So they don't necessarily look at the whole breast, they're just focusing on the area of the breast where it was found. And they often will do an ultrasound at that time. So I mentioned tomosynthesis. So this is really basically the difference is that one is a 2D or two-dimensional scan and one is a three-dimensional scan. So historically, we were doing mammograms as two-dimensional, and now we've evolved to the 3D mammogram, which is with tomosynthesis. This is a slide courtesy of UCLA. We do have the tomosynthesis available at UCI, and a lot more centers are having this. This is something I would highly, highly recommend when you're going for your mammogram. Make sure that they do. You can ask, do you do a 3D mammogram? Or you can ask specifically, do they offer tomosynthesis? Speaking from personal experience, I mean, I've had patients where the 2D mammogram doesn't pick up anything, but when they get the 3D mammogram, there's an abnormality that can lead to a biopsy. So the technology is pretty much the same. They're just using low dose imaging, low dose X-ray to examine the breast tissue. Your experience is pretty much the same. The difference really is time. So length of 2D mammogram is about 2 to 3 seconds, and it's maybe 1 to 2 extra seconds by getting the 3D mammogram. So, and then if you look here at the imaging resolution, on the left is a picture of just a regular mammogram. Nothing obvious is popping up, but on the right, you can see this small star-like mass in the upper breast, which turned out to be cancer. And it was not seen on the 2D, but it clearly looks very different and stands out compared to the 3D, to be compared to the 2D images. So another example here of a mammogram versus tomosynthesis. On the left, no lesion found, but on the right, you can see this pops right into view. So it really is powerful and makes a big difference. So please, if you're getting a mammogram, ask about tomosynthesis or a 3D mammogram. So next is ultrasound. So ultrasound is basically what I imagine many of you who have been pregnant have had, and basically they put the gel on your belly and they use a probe as imaged here in the upper right, where they're imaging the area of abnormality or where somebody may feel a lump. And then they have these are pictures here of different categories of how suspicious it looks. So category 3, you can see it almost looks like to me, I see like a surfboard type of shape. That's described as pretty normal appearing, could be just a cyst. And then as you progress down, you can see the shape and the edges and the borders and just in general, it looks a little bit messier and not as cohesive. And so really the ultrasound appearance can be very helpful to correlate with mammogram. I've seen it many times where the mammogram looks abnormal, they do an ultrasound, but it actually looks benign. And so then that can really then change the recommendation from biopsy to repeat imaging in 6 months. So what about breast MRI? That's the last type of imaging that's very commonly done for breast cancer screening, especially if there's a cancer that's diagnosed. A lot of breast surgeons will order a breast MRI because what they want to make sure is that that's the only spot, that there's nothing else that the mammogram may not have caught or the ultrasound may not have caught, but that may be picked up on an MRI. So on the top left is a picture of how a patient is positioned. So basically, the mammogram we talked about, you're basically standing up and the machine is moving around you and compressing the breast. Ultrasound, as I showed you, you're basically laying on your back, your arm is up, and the technologist is applying the probe. With the breast MRI, you are laying on your belly, and there are these little cups, basically, into which the breasts lay. And it's on both sides. It's almost like if any of you have had a massage, they've got a headrest for your face, and they can give you headphones to help block out the noise. MRIs are really tend to be very loud, and this exam takes about 20 minutes or so, give or take, sometimes a little bit longer. They often will put an IV in to give you IV contrast, and these are some of the images that you'll see. So you can see, and they'll do different sequences. So I don't know if you can tell just the inside of the breast. So this is the right breast, this is the left breast, it's reverse. It's like if you were looking at the patient when they were standing up. And so you can see this mass, and not as obvious in panel A, panel B looking very bright, kind of can see it in panel C, and you can definitely see it in panel D. So they do a variety of sequences to see if there's any abnormality seen, because sometimes some sequences are better than others. Any other questions before I move on to signs and symptoms? I think I see somebody.
Heather, go ahead.
Hi.
Hi.
Yeah, so I have a question. I was at a cancer retreat and there was a gal that was a cancer survivor,
Okay.
and she said that she had dense breast, didn't know it, and was not she had the regular mammogram,
Okay.
and yeah, wasn't told to get the 3D mammogram, and they missed her cancer.
Oh,
Yeah, exactly. And so then, eventually she found out, and so she suggested to me to find out what I have. So I had a mammogram, I think in March or April, and I got the results back, and everything was fine, they said. And then I asked, I went to a different appointment. I think I went to the gynecologist or something. And I said, can you tell me, um, do I have dense breast? Can you,
mm,
because they didn't, I didn't ask at that time, and I don't really understand how to read the results. And the gal said, yes, you do. And I said, okay, I would like to get a 3D mammogram. This was suggested, and I actually, I can't remember if I had done research before or after I had asked, but anyways, I have since done research, and all my research had also suggested that yes, you should get a 3D mammogram. And so I didn't even get time to actually, the gal had given me a phone number. I hadn't even had time to call. And then I get an email from someone from that department saying, you can't have a 3D mammogram until a year.
mm.
And so, anyways, I wanted to get your opinion on this and see just kind of what you thought. And just to give you a little bit of background on me, um, I I've never had a kid, don't plan on having a kid. I don't drink. I just turned 50. Um, I'm in remission for a cancer. So my doctor did say, you're at a higher risk for another cancer.
Yeah.
So I just wonder if I haven't emailed this woman back, but I'm just wondering if I should be pushing this and trying to see. I don't know if this is I have Kaiser. I don't know if this is like a Kaiser thing where they don't want to pay for it,
Yeah.
or if they're like, oh, you don't need it. And which is because they're like, oh, the results look fine. You don't need it. So
Yeah, I mean, thank you for sharing. Thank you for your question. My
yeah.
best guess is you had a normal 2D mammogram, and per their recommendations, the recommendation is repeat in 1 year. And it's probably financially driven that unless you have a problem, they're not going to repeat it for another year
Mhm.
unless you pay for it out of pocket or go elsewhere and potentially then pay for it out of pocket. Uh,
Right.
I don't know if you do self breast exams or if you feel anything abnormal, then it's a no-brainer, right? Then you call your doctor and say, look, I feel a lump in my left breast and I want to get, and then they would call you in and probably do a diagnostic mammogram and do an ultrasound and or an MRI, right? Like that would just kind of open the door where they would just start doing additional testing. It's a tough situation that you're in, right? I mean, you're 50, you're at the age in which you're getting screening. It sounds like you have some dense breasts, which is very common in younger women, such as yourself. We
Okay.
consider younger women 20s, 30s, 40s, sometimes 50s, depending on the women. And then our breast density changes as we get into, I think, menopause and perimenopause. And some women just have naturally dense breasts, and that just is always the case. So I don't know how to answer your question. I mean, I think if it gives you peace of mind to get a 3D mammogram, then I would push for it. If you,
Yeah.
and but if you don't feel anything, you're like, okay, now at least I know I'm informed and next time I go, I'll make sure that I insist on getting a 3D mammogram. I think those are your choices. I
Yeah.
mean, unless you want to pay for it out of pocket.
Yeah. It would make me feel better. And I
Yeah.
also feel good knowing that I do have dense breast, and I will push for it next time. I appreciate, I had never even heard
Yeah.
of such a thing of just asking for it up front. So moving forward, I'm always going to ask for it. But I am going to, because I didn't even ask for it. So I'm also wondering, how like that whole telephone game, like I don't even know
Mhm.
if the woman got the right information, because she never heard it from me. She heard it from from another woman. So who knows what she heard? So I'm going to email her myself and just say, give her the reasons why I want to get it done.
Yeah, and to be honest, that's why I wanted to include this. I mean, even like a lot of my friends and family don't necessarily know this too to ask. So I'm just trying to spread the word and so people are aware and informed. And I think health institutions are catching up to this. 5 years ago, not everybody had tomosynthesis, right? But more and more centers, especially big centers, are getting it. So I wanted just to share that so you can ask wherever you're going for your mammogram. Now, the other thing you can insist or ask for too is if you have dense breasts, ultrasound can also catch things that a mammogram may not catch, even a 3D mammogram. So, I don't know if you've had radiation before, if you have any other risk factors for developing breast cancer, um, you could also push and insist on that too. Or you could even ask for an MRI. You could talk to your doctor and say, and get them to refer you for an MRI. That's another alternative. If you don't want to get a 3D mammogram or you can't because you just had one, you could say, my mammogram report says I have dense breasts. I really want to get an MRI. I mean, again, with every test, there's always the potential that you could see something that's really normal that could lead to additional testing. So we don't, not everybody needs to get an MRI, but it's something I would at least talk to your doctor about, the possibility of what they think would be best in your case for screening, whether it's mammogram, 3D, ultrasound, MRI, or a combination of those.
Right. Okay. Thank you so much.
Yeah, of course. Of course.
Great info.
Good. And then there was another question. Out of the 3 screening options, is tomosynthesis the most secure screening measure? That is a tough question. I think and that's why I showed the recommendations for screening, right? I don't know if you can still see my screen. I'm going to just jump back to,
Yes,
are you able to see the screening guidelines there?
yes.
So, the routine recommendation is for mammogram, and I think tomosynthesis is, I think the short answer to your question is yes. A 3D mammogram, including tomosynthesis, is probably the most secure screening measure. That being said, there are other cancers that are not caught on those things, which is why, checking yourself is really important. And we'll talk about that later when we talk about signs and symptoms. But, being really aware of your body and changes that you may feel or see and not ignoring that, because if like the 26-year-old I mentioned who I saw last week, she felt something. She was in the shower and she felt a lump near her underarm, and then she came in and it actually wasn't seen on a mammogram, it was only seen on ultrasound. So it's hard to generalize, but the short answer is yes. I think tomosynthesis with mammogram is the best screening technique unless you feel something. Hopefully that answers your question. And again, if you're high risk, then maybe MRI might be helpful to do as well. Any other questions before we move on to signs and symptoms?
I think we're okay on questions. Thank you.
Awesome. Let me just change my view. Okay, there we go. You guys can see my slides, right?
Yes.
Okay, thank you. So, signs and symptoms. So this is a snapshot from the American Cancer Society website, which is a wonderful resource if you're looking for a place to go. And I have some more resources at the end that I'll share. So the most common symptom of breast cancer, that you can actually, a symptom meaning something you feel, is a new lump or mass. But not all lumps that you feel are cancer. So it's understandable that you feel a lump, you get scared, but it's just be aware that it doesn't always mean that it's cancer. Things that are typically more likely to be cancer are something that's a hard mass. It's got irregular edges, kind of like I was showing you on the ultrasound, and it's non-tender. I don't know if how many of you have experienced this. I definitely have, where it's, that time of the month and the breasts get tender, right? So cancers typically are non-tender, but they can also be soft and round and tender or painful. So it's really hard to say hard and fast just by examining if it's a cancer or not, which is why we need additional imaging, which is what we just talked about. So other symptoms that patients may experience is they can get swelling of part of the breast or all of the breast. You can get dimpling, and I've got some pictures which I'll show you later. So skin dimpling where it looks like an orange peel. Breast or nipple pain. A lot of times people don't realize that nipple changes can also be a sign of an underlying breast cancer. So that can mean nipple pain, pardon me, nipple retraction, meaning the nipple kind of, it's almost like it's getting like sucked in. Nipple or breast skin that is red, dry, flaky, or thickened. Nipple discharge. Now, if you're nursing, then having milk come out is normal. But if you have a nipple discharge that's different, especially bloody discharge, that can be a sign of something more serious, whether it's an infection or malignancy or cancer. It warrants further workup. Swollen lymph nodes under your arm or near the collarbone. So I'm going to demonstrate a little bit on myself. What we mean by the collarbone is, so these are my collarbones. There's a space right above our collarbones. This is called the supraclavicular area. This is an area where breast cancer likes to spread. The most common area that breast cancer likes to spread is the underarm, but it also can go here. Rarely, it can also go into the neck too. But the main areas, if you feel any lumps or bumps under your arm or over your collarbone, that's something to make sure you bring to the attention of a healthcare provider. Now, I don't know how many of you shave under your arm, but I do. And sometimes, you nick yourself, you can get a swollen gland and then it goes away. But what we're talking about here is basically something that's not going away or is growing in size. So next, I wanted to share something that Rebecca shared with me, which I love these next couple of slides, where basically it's Know Your Lemons Foundation. And I love this because I think it's a really nice illustration of things to watch out for, things we were just talking about. So what can breast cancer look like or feel like? So we'll go across this dozen lemons from top to bottom. So thickening, if you can see there's a dashed line there, the skin of this lemon is a little bit thicker. It looks a little bit darker in color. So if you notice any thickening area of skin on your breast, that's something to be aware of. Dimpling, you can see on this lemon on the side, there's like an indentation. That's not typically a normal finding of a breast. Crusting of the nipple. So here you've got the end of the lemon, but basically if it looks abnormal, especially, most of us have two breasts, so you can compare. Most breasts are not an exact symmetric pair, but if you see a nipple on one side that looks like this and the other side does not, that's a sign that you should definitely get that checked. If you feel like a portion of your breast is red or hot, kind of here in the lower outer section of this lemon, that's something that could be a mastitis or an infection, or it could represent an underlying cancer. We talked about this fluid coming out of the nipple, whether it's clear or bloody or some combination thereof. That's not typically normal. Skin sores, where you have indentations or hardening or changes of the skin surface. Any bumps, as you can hopefully see on this lemon, there's this bump sticking out. So if you have a prominence sticking out from the breast, that's something to be aware of. Growing veins, this is not something I've seen a lot of, to be honest, but it can happen. Where if you notice that the veins are more obvious on one breast than the other, that can be a sign of an abnormality. Sunken nipple, we were talking about this, where it's kind of sucked in or inverted or inverting or flattening. And now, just because, I've had many women where I see them and their baseline is their nipples are flat or somewhat sunken in, and that's okay. If that's your normal, I'm not trying to show you these to alarm you, but just the key is it a change from your normal baseline, which is why we should be comfortable and aware of what our normal is. A new size or shape. So this, as you can see, does not look like a normal lemon. It just looks very irregular. Orange peel skin, you can see it kind of looks like an orange. You can see almost like the pores of the skin of this lemon, and then a hard lump. Basically, I think the seed is what's meant to represent a lump within the lemon. So what's inside the breast? Again, continuing the lemon analogy. So if you were to cut the lemon in half, here's what the nipple represents, and these are the milk ducts. It almost looks like a tree, which is how I describe it to patients. And that's where these are the glands, the milk lobes that look and feel like soft peas. That's where the milk comes out from the nipple. This area, so the nipple is just that central part. The dark area around it is called the areola. Most of our breasts is just fatty tissue. You've got the skin, The ribs sit right underneath the breast. A cancerous lump can feel like a lemon seed and usually or can feel like it's not moving, it's just fixed. We talk about the milk lobes and then the lymph nodes. They can feel like soft beans. So on that note, just because you feel a lymph node doesn't mean it's abnormal, especially in women who are very thin. It's very common to feel lymph nodes, but the key is it getting bigger? That's when that kind of raises some flags as to, okay, this should get checked out. Early detection really does start with you. You know, one of the questions that was asked, right? I mean, getting a mammogram, let's say even if you get a 3D mammogram today and a year from now, I've seen patients who in that 1 year span, they can develop an abnormality. You know, like I had a lady I saw recently, she had a normal mammogram in, I think, April. And then in June, she had a lump that she felt and she came in and got checked and turned out that it was a cancer. So early detection is the key. So if you find something, you know, I think it is helpful to check yourself. Not that you need to check yourself every day, but periodically checking, just being familiar with your breasts. Do they feel dense? Um, are they tender? Do you have normal lumps? Do they come and go with your cycle or with age? Um, Make sure you tell your doctor if you're having something. If you don't have symptoms, then you start here by getting your mammograms like we talked about. If they need additional imaging, they will call you back as we discussed for ultrasound or an MRI or a biopsy. And really most biopsies turn out to be benign. And just all I will often do is kind of put you on the radar for making sure you're getting your screening, maybe getting more frequent screening. We talked about mammograms are typically done once a year. Sometimes we'll do them every 6 months, mammogram and ultrasound and or MRI, depending on the findings and the biopsy results. So again, just to summarize, if there's an abnormal finding, they usually do additional scans. We'll often refer a patient to a breast surgeon and then consider either surveillance, meaning just follow-up imaging, or biopsy and or surgery. Any questions here before we move on to section 5, which is we'll talk about treatment.
Yes, I got a message.
Yeah.
Advances in screenings, but
Mhm.
treatments do not seem to be caught up in cases of DCI, which I was told is the majority of breast cancers these days, and generally no signs or symptoms of DCI. Can you tell us about DCI, especially latest treatments?
Yeah, so it's DCIS, ductal carcinoma in situ. So actually, I'm going to go back to the lemon diagram. So a lot of the breast cancers typically start within the fatty tissue. And so, but these are ducts, DUCTS. Okay, so if you have a cancer that forms within the duct and it's limited to the duct and doesn't pop out, that's called a ductal carcinoma in situ or DCIS. And you're right, DCIS is like it typically shows up on a mammogram with calcifications, like one of the earlier mammograms that I showed you, and it typically does not have any symptoms. So, you know, I think as we have advanced our imaging abilities with mammograms and, you know, going from 2D to 3D, we're catching patients with earlier stage cancers, including DCIS or non-invasive breast cancer. The treatment for DCIS is generally the same as invasive breast cancer. Sometimes we can omit certain parts of the treatment, which I can touch on as we get into the treatment part of the talk. Um, so the main question is, how does treatment differ? Is that correct?
Or if there's any latest treatments for DCIS?
I mean, the treatment is generally the same as invasive, as an early stage invasive breast cancer. So we don't necessarily treat them differently, except I think there's been more studies that have come out that have shown and supported that in women above the age of 70, sometimes we can scale back on treatment for them. Meaning, for example, if they get a surgery done and they take a hormone tablet, maybe we can skip radiation, or vice versa. If they get radiation and they can't tolerate the tablet, maybe they skip that. Or they get a lumpectomy and decide that they just want to watch. So in DCIS, especially in older patients, sometimes we can scale back the amount of treatment that we're doing because the odds of that turning into a breast cancer, an invasive breast cancer, is roughly 4% per year. And so that's something that, you know, weighs into the discussion when I meet with patients in consultation. We talk about that. You know, I have patients who then decide, okay, I've had my lumpectomy, meaning I've had them go in and remove the cancer. I'm just going to keep an eye on it. And only act if it comes back again.
Thank you.
Hopefully that answers the question. All right, I'll move on to treatment. So there are lots of different types of treatment for breast cancer. Number one is surgery or an operation. And we'll go through each of these a bit in detail. Radiation therapy is basically, that's what I do. It's we're using a machine to aim at the breast to give radiation treatment. It's basically a high energy X-ray that goes through the breast. Patients are not radioactive. They don't glow in the dark. They don't set off metal detectors. They're safe to be around other people. I think radiation gets kind of a bad rap, but it actually is really well tolerated and a relatively straightforward treatment. Chemotherapy is basically something that's typically given intravenously, meaning through an IV or through a port. Endocrine therapy is a tablet that you take once a day, typically anywhere between 5 and 10 years, depending on the scenario. And immunotherapy is also something administered by medical oncology that can sometimes be helpful. So for all of these treatments, there's 3 main specialists that administer these treatments. So we have breast surgeons, we have radiation oncologists, and we have medical oncologists that are doing 3, 4, and 5. There's also radiologists who are the ones who are reading the imaging, and we have pathologists who are the ones looking at the slides from the biopsy and surgery. We actually have a tumor board. Most hospitals, most big hospital systems have tumor board where we discuss all breast cancer cases. And at that discussion, it's all of those specialists sitting together and reviewing cases to discuss the next steps in treatment. So let's talk a little bit about early stage breast cancer. So the standard treatment is a lumpectomy followed by radiation therapy plus or minus endocrine therapy. So on the left here is a diagram of the surgery. So you've got the breast, you've got the nipple, and typically what I've seen a lot of surgeons do is they go in right around the areola, right at the edge of the areola, go in and kind of track along underneath the fat, reach the cancer, go in and remove this, and then take it out. And it's really nice because in the past they used to put the scar and incision right here. And now if you, a lot of surgeons that I work with, they use the areola because that it's a natural edge that's there. So the scar really heals nicely and blends in. This is an example on the right of a woman getting radiation treatment. So basically she lays on this table, arms are up, there's armrests, and then this is the machine at the top of the picture out of which comes radiation. This machine can rotate around the patient. So it doesn't, this is actually probably not the best picture because it looks like radiation is going through the breast, but in fact, the machine moves at a different angle and gives radiation from the side to avoid going through the heart and lungs and so forth. So this is typically how we do radiation treatment after lumpectomy. The standard treatment is to do whole breast radiation treatment. There's also more and more evidence showing that there are cases in which we can do partial breast radiation treatment. Radiation is given every day, Monday to Friday, 5 days a week for approximately 3 to 4 weeks. The partial breast radiation is given every other day for only 5 treatments. So that's done in about a week and a half. And it's just case by case, which determines which patients get which treatment technique. In women with locally advanced breast cancers, a lot of them will often start with chemotherapy because what I mean by locally advanced is the cancer is kind of on the large side. And so it's hard to go in and remove that all surgically. So we will often give chemotherapy, help shrink it. Then it makes the surgery a little bit easier, whether they go in and remove just the lump or remove the whole breast. Sometimes patients will get reconstruction at that time, and then a lot of those women will come to us for radiation treatment afterwards. Any questions about this before we move on to the last section? Okay, I will keep going. So some special circumstances, just a few topics to wrap up on. Men, so 1 in about 700 men develop breast cancer in their lifetime, so obviously very rare. And less than 1% of all breast cancers occur in men. Over the years, as I've been in practice, I've definitely seen men with breast cancer, so it definitely happens. And for the men in your lives, please, spread the word. And if you ever feel a lump or they ever feel a lump, and make sure that they don't ignore it. I think there's a common misconception that men can't get breast cancer, but they can. And it's independent of breast size as well. BRCA mutation. So It's a rare genetic mutation, or BRCA. There's BRCA1 and BRCA2. If that is in your family or you carry that mutation, there is an increased risk of developing breast cancer and ovarian cancer. Typically, those women who are found, or men who are found to have this genetic mutation, the recommendation is typically to do a mastectomy, meaning remove both breasts, and a BSO, which stands for bilateral salpingo-oophorectomy, which is a fancy way to say taking out both tubes, fallopian tubes and ovaries, because we want to get those out because they can develop cancer. Lifetime risk of breast cancer in people who have the BRCA mutation is 60%, so it's quite large, versus 13% if you do not have the mutation. So does everybody get genetics testing? No. You know, if I have a 75-year-old woman, postmenopausal, small cancer, there's probably, and no family history, is probably not a reason to get genetics testing, but we've got guidelines that we follow in terms of for whom genetics testing would be indicated. And then inflammatory breast cancer, this is one of the most aggressive types of breast cancer that we see. You know, somebody asked a question about DCIS. That's the best case scenario, technically classified as a stage 0. This is a much more aggressive type. These women often present with, as you can see on the left, their breast is enlarged, it's swollen, it's red, kind of like the picture here. And it can look this dramatic. The skin looks like an orange peel. The classic board exam question that we would often get when I was in training was, you know, you have a woman who's nursing and she comes in with an enlarged, inflamed red breast, and they think it's mastitis, meaning an infection of the breast from a clogged duct from breastfeeding. You give her antibiotics and it does not get better. And the breast continues to get more swollen and enlarged. And it looks very inflamed. And I think that's where the name came from, inflammatory breast cancer. These women all must have chemotherapy, a mastectomy, meaning remove the whole breast, and radiation therapy. So God forbid if any of you were ever to see anything like this, this is something you got to act on very, very quickly. And there's also pregnancy-associated breast cancer. So basically their definition is not necessarily just during pregnancy, but also in the first year postpartum is classified as pregnancy-associated breast cancer. Most women in this scenario present with a palpable mass. It affects about 1 in 3,000 women who are pregnant. So thankfully very rare, but I've definitely seen this. You know, a lot of times what trimester they're in determines what type of treatment they can get. I cannot give radiation to anybody who's pregnant, but if they're postpartum, I can definitely do that. Chemotherapy you can give in certain trimesters. And then surgery, the anesthesia can only be given in certain trimesters. So it can become very complicated, but clearly it is a possibility. So definitely you don't want to ignore the breasts when you're pregnant. So last thing is just really a couple things is resources. The American Cancer Society has a great website and resource. Susan G. Komen has a really wonderful website, and of course, Cancer Support Community. And I thank them for having me and all of you as well. And just wanted to share their information in case you want to share this and pass this on to any family or friends who may benefit from the resources that they offer and provide. And thank you all for your attention. And hopefully, if you have any other questions, please let me know.
I had a question. When I was nursing my child, I got a very hot and the milk duct was inflamed and clogged, and
Okay.
it was really extremely painful. Would that have had anything to do with me getting breast cancer later?
I doubt it. What was the interval from that?
Oh, it was a long time later.
Like we're talking years?
Yes.
Yeah. So extremely unlikely. Yeah, getting the clogged ducts and getting that mastitis or inflammation or infection within the breast with nursing is definitely common. And I don't mean, I just want to clarify, just because you have that in and of itself is not a risk factor for developing inflammatory breast cancer. In
Okay,
fact,
thank you.
yeah, in fact, nursing and breastfeeding can be protective.
All right. I had another question. If when when you're finished with all the treatment, you know, the radiation and chemo and everything, and then you go for a mammogram, should you be getting a high risk mammogram again, or should you just be getting the regular mammogram?
By high risk, do you mean the diagnostic mammogram or
Yeah,
screening mammogram?
yes, or any special, should you get any special treatment because because you had breast cancer in the past, but recently?
Yeah, that's a good question. Usually, from what I've seen, most commonly, I think they do a screening mammogram, unless there's an abnormality. But really, honestly, it's typically the breast surgeon that makes that recommendation as to what type of follow-up imaging a patient should have. Like I've had some patients, most commonly what I've seen is, they get their lumpectomy, they get radiation, and then 3 months later, they get their follow-up mammogram. And usually it's a screening mammogram, and then if there's any abnormalities, then they'll call you back for a follow-up diagnostic mammogram. I have some women where they'll get an MRI, let's say it wasn't picked up on a mammogram and it was only seen on an MRI, then they'll get periodic MRIs. Now you have to be careful about MRIs too, because MRI scans, when we do them for the breast, we typically give IV contrast. And I've learned that there is the gadolinium is the name of the contrast that they use with the MRI scans. And if you get too much gadolinium, it can accumulate in your body and it can cause other problems. So, many times I've seen breast surgeons, instead of getting an MRI every year, get one every other year and alternate that with ultrasounds and mammograms or supplement them with that. So just something to be aware of.
All right, thank you.
Of course. Thank you. Rebecca, I don't know if you're talking to the group. I don't hear you. I see you talking, but
Sorry, is that better?
yeah, yep.
Oh, sorry about that. I was just reading into the chat that there was, thank you, Dr. Priya Mitra. You explained things very clearly, and I agree. Thank you so much for your time, effort that you put into the presentation, and providing this workshop so we know more about this very important topic.
Of course.
Wonderful. I'm going to stop the recording.